Well, we want to welcome everyone here to Birmingham Bible Church this Wednesday afternoon. It's been raining here a little bit, so hopefully everyone is safe and dry wherever you are. And we just want to take a few minutes, of course, to thank our Facebook followers, to thank our YouTube subscribers. That's right. If you are not already subscribing to our YouTube channel, make sure you do that as well. We are BHAM BC, and we are also on Twitter at Beham Bible Church. So we are so excited that you decided to join us here today at Birmingham Bible Church worldwide. And so on today, we have a special town hall meeting today because it is Pastor Mason's desire to bring before you people who can educate all of us. And so, of course, we know the word of God says that my people perish for a lack of knowledge. And so it is his desire and my desire and just the entire church desire to make sure that we are educated just in every area of our lives. And so for those of you, I'm sure all of you know, because we've been just inundated with it, for over a little more than a year, we have been forced to work at home. Our schedules have been changed. Children have having to be at home virtually for schooling. Businesses have shut down. We've had increase in deaths, and just everything has changed. You know, Thanksgiving and Christmas, we really couldn't be around each other like we wanted to. And all of this has happened because of a virus that has entered our country, coronavirus or COVID-19. And so now we at over, I believe, 560,000 deaths here in the United States. Millions of people have passed away from this disease. We've had millions of people to contract it. And so, of course, the government tried its best to really try to get on top of it, slow things down, telling us to wear masks and to socially distance, avoid large gatherings until the vaccinations were released. And so I'm not gonna lie to you, I was one of those people. You know what, I'm gonna pass on this. I've heard about the Tuskegee experiment. How they gonna come out with a vaccination, and we just got the virus, and all this stuff is just running through my head. And so a family member of ours had shared a video from our speaker for today that she did in Nashville. And so me and my husband watched it together. And so, I was like, we were really convinced after watching her and just really explain the details of it. She really dispelled all the myths of things that I have heard about the vaccinations. And so we have before you today Dr. Consuelo Wilkins. She is of Vanderbilt University Medical Center. We are fans of Vanderbilt because that's where Pastor Mason got his kidney. So we are fond of Vanderbilt. But she's going to introduce herself. But she is the vice president of health and equity. She's associate dean of the health and equity there at Vanderbilt. And so I know that she has been recognized just as a leader for our people, for people who are in disadvantaged populations. And so we appreciate her coming on and giving us part of her time this afternoon to do this for us. And so I introduce to you Dr. Consuelo Wilkins. Hello, Dr. Wilkins.
Hello, Lady Pam. Thank you so much for that kind introduction. I'm really thrilled to be able to spend some time with you all this evening. And I feel like you could have given some of my presentation, though. You were given the stats and already have all the data, so I could have just come in and added a little bit to your presentation.
Oh no, ma'am, no, ma'am.
Well, I must say before I get started that I did not know a lot about Birmingham Bible, and we got the request, and my assistant, my program manager Kim, who is always really telling me that I should turn down more things, and she's going to say no for me. So she is responsible for that, and then so she brought the request to me. She's like, well, I think you have to do this one. So if you could convince Kim to get on my calendar, that's sort of the way to get on my calendar. So she looked up things about about your church and was just really impressed and shared all of those wonderful things with me. And so I really am delighted to be able to spend a little bit of time with you all this evening. So I'm going to share my screen, and hopefully you'll tell me, Lady Pam, if you can see it. Okay. So I'll just share a few other things about my background. So I'm trained in internal medicine and geriatrics. I did my undergrad and medical school at Howard University, did my internal medicine residency at Duke, and geriatric medicine at Barnes Jewish Hospital, Washington University, and have been in Nashville now for the last almost 9 years in roles at the Meharry Vanderbilt Alliance, and then more recently in the current role I have as Vice President for Health Equity at Vanderbilt. And of course, the last year with COVID-19, I think no one could have been fully prepared for what this virus brought forward. And this new virus, something that we really didn't know a lot about the specific one, COVID-19. We know about the coronavirus family of viruses, and there are people who've been studying it. But the disease associated with this new virus that was just identified in 2019, we had to learn a lot about it. And of course, we have over the last 13, 14 months now about how quickly it spreads, and how people before this had very little, if any, immunity already. So that's where we are now with the vaccine, and I'll come back to that. But there's certainly been a lot of questions, a lot of concerns, and a lot of unknowns about COVID-19. I think that's made it particularly difficult to discuss, because so much information is coming in. It's coming in quickly. It's changing, and so it certainly resonates with me that it's hard to keep up, even for those of us who've been really deeply embedded in this since the beginning. So many things are new, and so keeping up with all that information has been a challenge. And then, what do you believe? What sources of information do you trust? Well, so we've learned about how it's transmitted. This virus is something that, again, early on, we weren't quite sure. There was a lot of hand washing down sanitizing every single surface. We have known that it certainly has spread person to person, coughing, sneezing, talking. At church, of course, one of the challenges, you're singing, shouting, that those would be ways of transmitting the virus. We know now that there's less of a risk of transmission on surfaces, but person to person, that expelling the virus is the primary way that this virus has spread. There's been also a lot of concern about how long you have symptoms, and can you have symptoms? Can you have the virus without having symptoms? And so we certainly have learned that there is a wide range of variability. So some people will get symptoms within a couple of days of being exposed to the virus, and for some people that might actually take longer. And of course, some people have very little or may not have symptoms at all, what we would call asymptomatic. But even even if you don't have symptoms, you can still spread the virus. And so that's a lot of the precautions that have been encouraged with wearing masks and maintaining some sort of social distance. It has been really the key to prevention. The common symptoms, again, you all have heard these, I'm sure. Your most common symptoms: fever, cough, shortness of breath. Some other symptoms, and some people had just sore throat or body aches. Some people, the first thing they noticed was a change in their sense of smell and taste. So a lot of these can be associated with more common things as well. Body ache, headache, at least, a few times a year, most of us have some sort of headache or a body ache. And how do you tell the difference? But again, being cautious, and if you have a fever, if these symptoms don't go away, and to the degree possible, if you feel a little bit ill, trying to make sure that you're maintaining distance away from people until you can get tested is really important. Of course, the treatments for the coronavirus, like most viruses, they're not just antibiotics waiting around. It's not bacteria. So it's a virus, and viruses typically are more difficult to treat, which is why we want to try and prevent them, which is why with the flu virus, we have vaccines for that. So ideally for viruses, we are working on prevention and immunization. So still the treatment is, if you're early, if you have mild symptoms, isolate, stay home, stay away from people. We're treating symptoms. And this, of course, was also a challenge early on in the disease. There was no known effective treatment for this disease. There were lots of questions, lots of potential medications that might work, but early on we had nothing. Months into this pandemic, remdesivir, a drug that you get intravenously. If you have moderate to severe symptoms, we were giving that. Some people, we were giving steroids. Those again for people who were in the hospital. But just for across the board treatments for the coronavirus, for COVID-19, not a lot of effective treatments. There's some more that recently, ivermectin, that's been purported to be helpful, but to the degree possible, still, ideally we're preventing coronavirus, COVID-19. We're distancing, we're practicing these preventative strategies, and we're getting vaccinated. And so when I made these slides a month or so ago, this was based on December 2020, when we had 2 vaccines. I will talk a little bit about Johnson & Johnson as we go through. This is me getting my first dose of the vaccine. And so I like to make sure that I am practicing what I preach. No offense to to the preachers here. But I have been vaccinated. I did get my first and second doses, had just a little bit of soreness in my arm and no other signs. But actually, I was preparing my family to get waited on when I got my second vaccine. I was like, oh, I'm going to feel tired. Somebody's going to have to make dinner, bring me some, bring my food, so that I didn't get anything. I felt fine. So that's how it went down. So again, we've talked about a little bit about things you can do. You probably know all these already. I think the one thing that I would reiterate is as you're trying to make sure that you are socially distanced and you're wearing your mask, make sure you're covering your nose and your mouth with your mask. I think that's going to be more challenging as it gets hot. I think we'll see more of those chin masks and everything, but do your best to try and cover your nose and your mouth. We will expect, though, to see that some of these preventative strategies, as we've learned more, like being outside. If you're vaccinated and you're outside, you'll probably see more um, loosening of those restrictions, and there'll probably soon be recommendations that you don't need to wear a mask if you're outside and you're vaccinated. So those are some things that we should be thinking about. Of course, we learned early on during this pandemic that some populations were being affected more than others. So these really striking and unfortunate disparities among African American, Black, Hispanic, Latino, American Indian populations are things that we noticed very early on. These populations, you know, 2 to 3 times more likely to die from COVID-19, 3 to 4 times more likely to be hospitalized. And so, of course, again, I don't have to tell you all, I'm sure you've seen it in your community. And, you know, I can only imagine, you know, some of the same challenges we've experienced in healthcare, you're experiencing with your parishioners' families, and having to deal with, you know, really the devastation, loss of life, and other, you know, impacts, indirect impacts of this virus, and not being, you know, not being able to work, staying home, the children, all of those things are disproportionately impacting people of color. So I like to point out, though, some things that I think are really important about these disparities. And that is, often as you've heard these described, people will discuss them as if these differences are due to some, you know, inherent biological differences by race. And that is not true. So the reason that you're seeing, or we've seen, you know, disparities among these populations are because of social structures, socioeconomic factors, systemic racism, chronic disinvestment in communities that have really set us up to have poorer health. So you might be thinking, well, I heard all these things about people having more diabetes and hypertension and obesity. That is true, but that is not because of race or ethnicity. That is because of living in these conditions where we're stressed, we're socially deprived, we have less educational opportunities, have to work harder. All of those things over time, you have a biological response to these things that increase your risk of having these conditions. Now, that doesn't mean that you know, diet, exercise, behaviors don't add to it, but those alone are not the only reasons that we are predisposed to this. But I want to make sure that people don't believe that we have some, you know, different genetics or biology that are really contributing to these differences. This this graphic, this table here, this diagram is from 2014. So this is well before we ever knew about the coronavirus 19. This is a depiction of what we should have been expecting for any kind of infectious disease epidemic, that people who live in housing that's crowded, so more people in a household than others, the people who can't stay at home to work, who have to go into those retail jobs, those frontline grocery store jobs, people who have to ride the bus, public transportation, ride with other people. If, again, you are in states where you're chronically stressed, poor nutritional status, all of those things are increasing your risk of getting coronavirus or any other infectious disease epidemic, regardless of your race or ethnicity. So these are factors that we know contribute to the excess death and the hospitalizations. And so these are things that, you know, if nothing else, we need to be thinking long-term how we're going to address these things and how we're going to be prepared for the next pandemic, because we should expect that this is going to happen again sometime. We don't know exactly when, but it is likely to happen. And we want to make sure that our communities are not disproportionately impacted in the same way. I talked some already about the communication. So, over time, long term, over these 14 months, trying to get information out from trusted sources into the community, addressing these concerns about the safety of the tests, treatments, vaccines. All of these have been incredibly challenging. And of course, some of the things that we've seen with limited access to testing and vaccine, and how we've implemented things like contact tracing, sharing information, personal information with law enforcement. All of these things contribute to this, negative environment around information and how do we keep our community safe. So at the same time that we really, really need to do it, it's incredibly hard to do. And so I really do appreciate Birmingham Bible having this opportunity to share information. And I want to make sure that I leave enough time at the end for questions. The indirect impacts, I think that's really important. We have to start planning for these long-term impacts. As a physician, of course, I'm very concerned about the health, the initial health impact, but I'm also concerned about the long-term impacts on your health because of the other indirect things that are happening due to this virus: loss of income, childcare, the educational status of our children. All of these things are going to have a negative effect long term on our communities. So my work in this with COVID-19 started, again, early on when our CEO at Vanderbilt said, again, very early, I don't like what I'm seeing here. I'm seeing that there are worse outcomes among, minorities, among communities of color. And so, I was charged with coming up with this overarching strategy for how we would make sure that we could get a handle, understand, try to address some of these inequities. And many of you may not be that interested in this paper, but this is, the work that we did has been shared across the country, and others have tried to come up with similar strategies. And one of the things that we prioritized was we have to have the data. You may have heard discussions about this. If we don't have the data about race, ethnicity of people, what language they speak, we don't really know where the problems are. So we put a lot of effort into that, but we also put a lot of effort into working with community organizations, with trusted partners in the community to share information, to host town halls, to think about how to support communities. And I think that's something that we should be pushing again more broadly for long-term strategies, not just for COVID-19. So I do have data on what that looked like in Nashville at Vanderbilt, and of course in Nashville we have Meharry Medical College, who have been leading a lot of the work in doing the testing in the city, and also vaccinations. And we have an incredible CEO and president of Meharry, Dr. James Hildreth, who's an immunologist and on the FDA committee that's over, approving the emergency authorization. And so, there's been a lot of work in Nashville outside of Vanderbilt. So this is just at Vanderbilt. I just wanted to share that, this is up through the end of March, we had tested in-house, done our own testing on almost 200,000 people. And so that's the data that we've been looking at, and disaggregating, looking across race, ethnicity, and also language for those disparities. And so you'll see here that the groups that had the highest disparities at Vanderbilt were actually people who spoke languages other than English, and those were some of the populations with the greatest disparity are Arabic speaking. And in Nashville we have people who are Ethiopian and speak Arabic, and people who are from other countries of origin and speak Arabic. And so they are together. And then we have people who are Nepali speaking, and we had a huge cluster there. So being able to work with community organizations who support these was really very important to us early on. For tonight, I did pull some data about Alabama and wanted to make sure that I could share something that was relevant to you all. So this is your state profile report. You can go and find this on the CDC website. So it's looking at data from the last week and change, and just like you would imagine, green is good, yellow is pause, and then this red is not so good. So in the last couple of weeks, you're seeing a little bit more cases. And so this is 42 cases per 100,000. So last week here in the yellow, so that's up here. It's actually better from the previous week, but it's still not good. Positivity rate, 5.4%. Confirmed cases, hospital beds there, so you're doing okay. Hospitalizations, but your death rates are not looking good. 2.5 deaths per 100,000. So that's very red here. You're at a moderate transmission, and so I think this is important for you all to know as you're hearing in media and social media, the virus is, the pandemic is over, everything opened up. That is not the case. You all still need to be protecting yourselves and your families and your communities. This is from that same report, and so you can look at the transmission by county. So the last page was showing you Alabama as a state, and then you can look here and you can see the transmission by county. Now, Lady Pam, I don't know if you still have your audio. I'm not going to attempt to say where Birmingham is because my geography is not that good.
Birmingham is Jefferson and Shelby.
Jefferson and Shelby. And what color is that? Is that orange?
Hold on, I'm looking. It may be red. Hold on.
It's in this area here.
It's in orange. Yeah. Jefferson County it's in orange.
Yes. Okay. Yeah. Oh, yes, it is down here at the bottom. You can see that. Jefferson, okay. So you all can find this. I know Birmingham, there are multiple counties in the area. So you live outside of Jefferson, you can figure out but you can see you're a little hot there. You're orange and red. So you all are not out of the clear, and you have to start thinking about how you're going to protect yourselves. So let me shift to the vaccine. So we now in the United States have 3 vaccines that have been approved for emergency use. So they're not FDA approved, they're approved for emergency use, and I'm happy to answer questions about what that means. The first one that became available was Pfizer, and the second one was Moderna. I'll talk a little bit more about them. They are the same kind of vector, mRNA, and then the most recent one that has been approved for emergency use is Johnson & Johnson. That's a different kind of a vaccine, and that's with an adenovirus vector. Again, happy to talk more about the technical aspects of that. And I'm sure most of you have been hearing this week in the last few days that there has been a pause on the use of the Johnson & Johnson vaccine. That is because of, as far as we know, 6 cases of blood clots in women. And that is less than 1 in a million as far as occurrence, but because it is something that has been identified in people who received the Johnson & Johnson vaccine, the CDC and others have recommended a pause so that they could take a closer look at the data and to really try and determine if there is an association with Johnson & Johnson. There has been There's no effect of that pause on the Pfizer or the Moderna virus vaccines. And again, they are mRNA, so a different kind of vaccine. A lot of talk about the approval process for the vaccines and the efficacy data. You'll see just in a minute that all of these vaccines, the data show that they are efficacious. So they, when compared to people who did not get the active vaccine, they were 90 to 95% for the Pfizer and Moderna vaccines efficacious. So I'm going to talk a little bit about how the mRNA vaccine works. So this is a newer technology. It's not new in the last 2 years. And so again, people have been like, well, how is this possible to get the vaccine so quickly? And what's the process? And so vaccines, of course, as you saw on the last slide, there are a number of different vaccines that were in the works early on that have different ways that they've been developed and the way that they act. But the overarching goal of vaccines to get your body to make antibodies to prevent you from getting sick if you get exposed to the virus. And so they work in different ways. The mRNA, so messenger RNA vaccines, the Pfizer and Moderna, really have been developed to tell your body to make antibodies to the specific spike protein that has been found on the coronavirus. So I think some important things that you really want to know about the mRNA vaccine is that it's the messenger piece. So the M is messenger. It's telling your body, it's giving your body instructions for creating this spike protein so that your body can actually make antibodies to it. So it is not telling your body to make the entire coronavirus. It does not have a live virus in it. It is basically giving your body instructions to the spike protein that's on the surface of the virus, and then your body has to do the work of making the antibodies. The messenger RNA, so that's the instruction manual, is really, these are proteins. It's telling your body how to make these different types of proteins. It's a very small amount of RNA, not DNA. So it's not DNA. And importantly, this is the injection is getting to your muscle, and then your immune system recognizes it, and after it makes a spike, and then the antibodies do the work. So the symptoms that people are getting with the fatigue is really your body revving up its engine, making those antibodies. And so again, if you've had a cold and you feel those kinds of symptoms, and then all of a sudden you feel better, that's what you're feeling, but there's no virus that you respond to. It's just the spike. It's just that's what the mRNA is giving your body the message to do, is create that spike, and then it degrades. And so all of this is happening in this part of the cell, and this little, this circle here is the nucleus of the cell. The mRNA does not get into the nucleus. There's a protection here. The mRNA does not cross into here. This is where your DNA is. And so the mRNA coding is not affecting your DNA. It tells your body to make the spike protein, and then the actual mRNA dissolves. So imagine when you take aspirin, you take Tylenol, there's a coating on it, it goes in, it dissolves, goes away.
And Dr. Wilkins, I heard that I was looking at a video that said that the vaccination does that it will change your DNA. So thank you for that illustration. because according, what you're saying is the vaccination doesn't get into our nucleus, our cell nucleus. If it did, and it would change the DNA. It's just there to help us get antibodies.
Yes. I don't know if it got into the nucleus, if it would actually change your DNA. It's interesting because yeah, that's a really complex thing to do. We talk about all these sophisticated genetic studies and how you actually are gonna like change somebody's DNA. That's a really complex
Okay.
work to do. So, but you're right. What I'm saying is that it has no chance of even thinking about that because it never gets into the nucleus.
Gotcha.
I mean, I'm shocked with I was like, whoa, people think we could do that? Like just the one little injection and you go in and change the DNA. But yeah, no, it's that's not happening there. But I'll talk a little bit about, it's really important to me as a Black woman. And so I'm just sharing what I think about, not just for myself and my patients, but if I'm asking my family to take a vaccine, then I need to be able to tell them, how many people like them were in the study. So those are things that are important to me. Before I go to that next slide, just say those numbers: 95% efficacy for the Pfizer and 94.5% efficacy for the Moderna. 40,000 people in that Pfizer trial, 30,000 in the Moderna trial. And so these are the numbers that you can see here. I created this slide so you can see side by side. If you're looking, this first column, again, this is similar to how we were showing things at Vanderbilt, but for the US population, people over the age of 16, they're about 258 million. So these are the demographics here. For people who were in the Pfizer study, again, 40,000 of them, 9.8% of those people were Black, African American. So a little bit less than the US population, but not far off, about 10%. Similar for Moderna, about 10% people who got the Moderna, were in the Moderna study, were Black or African American. Now, could it have been better? Could it have been more? Would that have been great? Yes. But you all know it's not easy to get people to agree to be in clinical trials. And so I think it's one thing to say, yes, we would love to see more, but it's also, we have to recognize it's incredibly challenging to get people to participate in clinical trials, especially in such a short time frame. So, and I don't think I have a slide on that, but for the Pfizer study, for the people who got the placebo, so there were Black people who got the placebo and Black people who got the vaccine. Of the Black people who got the vaccine in Pfizer, not a single one of them actually got COVID. So, we do know that the vaccines don't protect you 100%, don't protect 100% of the people. So it is important to look at those things. So I just want you to know that I went deep into the data and looked, because I know my family is going to ask me questions when I start to, and my friends, when I start to say, hey, did you get your vaccine? We talked about common symptoms. Very, very common for people to have a little bit of soreness in their arm, sometimes fatigue, that muscle ache, a fever, headache, that these go away in 1 to 2 days. And that was much more commonly to occur after the second dose. So, a lot of questions we got early on were, well, all those things you were saying sound like the coronavirus, sound like COVID. So are you sure you're not giving us COVID? Well, I didn't say you get a cough, and I didn't say you get shortness of breath, and because those are the two most common things that we saw when you have COVID-19. Now, the fever is something that you would want to say, okay, well, I have fever, what's the temperature? Do I have any of those other symptoms? And if it's lasting more than a day, then that is something that you would want to be concerned about. But no cough, no shortness of breath associated with the vaccine. The Johnson and Johnson, this is actually a slide I borrowed from a colleague, in part because who lives in Massachusetts, so that's what the MA is there. We have not been doing a lot of vaccinations with the Johnson and Johnson, so that had not been a part of my slide deck. I added this in the last day just because of all of the things happening with the Johnson and Johnson vaccine. So that because people might be having questions or want to know more about that. I mentioned already that with the Johnson & Johnson vaccine, there has been a recommended pause in use of that as they're investigating 6 cases that have been reported of blood clots in women who had received the Johnson & Johnson vaccine. So in the Johnson & Johnson trial, there were about 44,000 people. You can see the demographics here. They actually had more people who identified as Black in the Johnson & Johnson trial, so almost 20%, and over 40% of them identified as Hispanic. So they had a lot of this study happening in Brazil and South Africa, Colombia, Latin America. So there was a little bit more diversity in the Johnson & Johnson trial than in the Pfizer and Moderna studies. I want to make sure I have a lot of time for questions, so I think I'm going to stop here and just say that it's important to continue to wear your mask after you get vaccinated. You're wearing a mask to protect other people. Depending on the kind of mask you're wearing, it also protects you. But at this time, there's not been a recommendation that you stop wearing your mask. I mentioned earlier, we're expecting that there will be some loosening of the guidelines around wearing a mask if you're outside, especially if you're vaccinated. But some of those recommendations are still being formed. So I will stop here and take any questions.
Okay. And thank you so much for, saying that we still need to wear masks. Because earlier today we had a live with a funeral director. We talked about getting your affairs in order. And so before we started going live, I was asking him, hey, how's, business going? And he said, actually, I have 15 bodies right now. He said, everybody is so lax with the wearing the mask that his cases, his clients have increased because of that. And so it's just so important. Let's get vaccinated, but we need to do our part still and we need to wear our masks. We need to use, those common sense things. So I appreciate you saying that.
Well, I'm really sorry to hear that. I mean, it goes along with what we just saw with the data, with the increase in death in the state. But I try to always make sure that we see so much of this in medicine and with this data that we sometimes talk about the numbers, but these are lives. These are people with family, friends, people who care about them, and every life is important. So that's some of what I try to say to people. We're still learning a lot about this virus still. I mean, there are things we don't know about the long-term impacts for people who do get it, but we do know that the virus has killed a lot of people. And if wearing your mask could help save a life, then we really should be thinking about why we wouldn't want to do that.
So we do have one question that came in. How long does the vaccine last, and will I need a booster? And I saw that earlier today because my husband and I, we're one shot down. And so we received the Pfizer one. And as soon as we got it, I was looking at the news and it says something about 6 months and may need a booster. So can you please clarify, are we going to need a shot yearly? Are we going to need a booster shot?
We don't know. We
Okay.
don't know. We don't know. So the good thing about the 6 months is that at one time people were saying, well, you might need a booster in 3 months. And that's when I was like, I'm going to have a hard time convincing people that, they're going to need another shot in 3 months. So far, we do know that the vaccine is the Pfizer, Moderna are protecting. Well, I think there's more data right now on the Moderna, but there's increasing data on Pfizer that it is protecting people for at least 6 months. And we're just going to have to continue to follow and see, how long are people protected. And so there's good epidemiology tracking that's trying to follow to see how long people are protected.
Okay. All right. And then another question, do standard PCR tests work for the second strand of COVID?
Great questions. I did have I think I didn't get to that. I did have a slide about the different variants. It might be too many it might be confusing for me to pull it up, but Lady Pam, I'm going to see if I can pull that slide up just really quickly, if that's okay.
That's fine. And when you please explain to some of us who don't know what a PCR test is, what that is.
Well, I think it's probably more important to know about the variants.
Okay.
But I'll talk about the different tests. So the PCR test is more sensitive and can actually detect the different variants of the virus. So we know in general that viruses mutate, lots of things, living things can have changes. So when we talk about variants, we're talking about the coronavirus 19 that has some different changes that we would call mutations. So shifts in proteins that can make it more contagious, can make it more deadly, can make it less contagious. So there are these different variants that that people have been tracking, that infectious disease specialists and epidemiologists have been tracking. So one of them has been seen more commonly, or was first identified, I should say, in the UK. So you heard about the UK variant. And then you heard about one that was from South Africa that was also more virulent, so more deadly. I did try to find this specifically for Alabama, and it doesn't look like you all are reporting the variants in the same way that we are in other states. So these are the different variants. So you can see here the UK and the South African one, so B117 and B1351 are different variants. So some states are actually doing the sequencing and looking at the percentage of, they're not doing it on every single test that they get, but they're doing a certain number and trying to see how frequently they're seeing these different variants of the coronavirus present. So, the technology around this is not that challenging, to be able to do some sequencing of the variants is not that complicated. It costs money. The test costs money. And so not every state or county or testing facility is doing that. And Lady Pam, will you repeat the question? I want to make sure I answer it.
Yeah. She said, 1 second. Okay, do standard PCR tests work for the second strand of COVID?
The PCR tests, as far as we know, are able to pick up a positive or a negative for all of the variants. But the sequencing is different, and that's a more complex test.
And I know for the state of Alabama, and that's I don't know how long ago it was, maybe a few months, but we did have one Birmingham man who actually died of the variant. It was in the news. He had two smaller children, but I don't know if that was before the vaccinations were
Mhm.
out. So that's the only thing I heard as far as the variants. So let me ask you, the vaccinations that we're getting now, will they protect us from these variants? You
Uh,
answered that already, but
we don't know to the degree that we will be protected, and so that is something that we're still learning about. You may hear some of the reporters and the public health officials talk about, especially in places like Michigan, where they're seeing a huge number of cases and a lot more variants, that we need to do surge vaccination. So we just need to send more vaccines there so people can get vaccinated, because we believe that's going to protect them. But again, I believe in being transparent. You know, some of this is just happening. You know, some of these variants we've just identified. So I'm not going to tell you that it's definitely going to protect you. But so far, the data that we have indicates that you will have some protection. It may not completely protect you. So if you think about it with the flu, the flu vaccines as well, if you what you get in your flu vaccine is not going to be every potential, you know, variant of strain of the virus. But if you have the vaccine, you are likely to get some protection from severe illness.
and do you know when it will be available for all children? I think now is it 16 and up? Is that right?
Yeah, so the Pfizer is the only one that is approved for 16 and up. The recent studies have been completed with 12 to 15-year-olds for Pfizer, and that data has been submitted to the FDA. So they are trying to amend um, uh, their approval, their emergency use authorization, to include 12 to 15-year-olds. It was actually very efficacious in that group, and it is expected that it will be added to the emergency use authorization. I want to say by July, but that's just looking back at the timeline. It's going to depend on a lot of other factors, I think, including, you know, of course, how quickly the FDA will act, and I think they will convene quickly, and then as soon as they do, we would expect it to be available. So.
That's what I kind of figured. I was thinking, they're probably trying to at least get it implemented before school starts in August.
Yes.
That's probably the idea, the thinking. So, okay, thank you so much for that. And so let me check real quick and make sure
I will say, Lady Pam, while you're checking that, I do have colleagues who believe that Pfizer will be, that the emergency use authorization for 12 to 15-year-olds will be in June. I Again, I'm more like, no, if I tell people in the community and it doesn't happen, then they're gonna call me and say, it's June 1st, where is it? So I'm more like, I need to see some different timelines before I go out on a limb with a number.
right, right. And then let me ask you, if someone has had COVID, they've tested positive for COVID, how long can they get the vaccination?
Um, I might have to double check on both for both of the vaccines, but we have been recommending that you wait for 21 days. But I will double check just to make sure that that hasn't changed. I think the question that we get more commonly is, should you still get the vaccine? And that answer is yes. If you have had, if you tested positive for COVID-19, it is still recommended that you get vaccinated.
And then what is the best mask to use? I see all kind people getting creative. They got bling on it. I mean, it's very creative. People, making their monies, making masks. And so what is the best type of mask to use? And then how can we continue to protect ourselves even though we're getting the vaccination?
So the best mask depends on what you're doing.
Okay.
So a cloth mask for everyday use when you are not really going to be around people. You're going to be in an area where you can be 6 feet away from them, 2 shopping carts away from people. You are fine with a cloth mask. If you are in a close setting with people, for example, if you work in a hospital and you're in close contact in the emergency room with people, we are still doing cloth masks for our healthcare workers. Some people would say, we should consider using more hospital grade masks in that setting. Of course, early on we had a limited supply, especially of the N95s. But if you have symptoms of any kind, if you have seasonal allergies and you just want to be sure you're not getting anything out of that, keeping it all to yourself, you might consider a surgical mask. But as of right now, we are not recommending that. I think if you are again if you're riding on a plane, if you have a higher grade hospital mask or N95 or something, if you have one of those, I would save it for that. I wouldn't wear it just in everyday use. There's no evidence that you really need that kind of protection in day-to-day interactions.
Okay. And then can a person be infected with COVID more than once?
Yes. Yes. We have had people who have had COVID more than once.
Okay. And then I guess from my understanding is that there's no medication to treat COVID. It's just kind of like you said, steroid shots or just kind of having the symptoms just go away. And so I guess how can we protect ourselves? Because we know COVID is going to be here. And then you mentioned that, hey, you never know, 100 years from now, another virus may spring up. So what can we do to protect ourselves now, just to make sure that we're protected, our families are protected as well?
So right now, it's still until you get vaccinated, the best prevention is to keep your social distance from people and to wear a mask. The best protection, though, right now is to get vaccinated. We know that if you get vaccinated, you're much less likely to get infected. And if you do get infected, your symptoms are milder. Now, there are treatments. I mentioned earlier, remdesivir is an IV treatment. There's still some other treatments that are being investigated, and we're still learning more about them. Ivermectin, that's one that there have been some publications about just in the last week. But again, remdesivir is an IV medication, so you have to be really sick and in the hospital to get that. Some people have gotten convalescent plasma, so that is for people who had COVID-19 and developed antibodies. They donate blood plasma, and we make we take the plasma and can give that to other people. But again, think about all the steps in that process. So if you can prevent yourself from getting COVID-19, that's much better than having to get an infusion.
And I guess, I'm seeing that people are slowly opening things back up. So, shops, businesses, churches. And I know we have to stick to our state guidelines, but what do you recommend as far as, gatherings of no more than so many people, or what is your opinion on that?
I think it depends on what you're doing. If you're able to gather outside, we're that is optimal, as opposed to indoors. And if you're indoors, I would really be focusing on how far away are you, how much of a social distance can you maintain between people, and then again, what are you doing indoors? So if you're indoors and you're having light conversation, you're not doing a lot of moving back and forth, not doing things where you'll be expelling potentially fluids out of people, then that's safer than if you're in a setting where you're really doing more things indoors.
And then one more question, unless I see another question in the feed. So I kind of hit on this a little bit, the Tuskegee experiment. That was a thing that got me. I was like, I'm not getting the shot because, they tried that, years ago, and I saw how that turned out. And so, like I said, I heard you talk about it on another feed, and Pastor Mason and I, we actually got our one shot. So we have one more to go on next week. But can you tell us a little bit about that and how that is different from this particular vaccination?
Mhm. So, in the Tuskegee study, or the U.S. Syphilis study, um, Black men in Alabama and Tuskegee who had syphilis were not treated. So these men were infected, and when penicillin was approved and known to treat Tuskegee, that treatment was withheld from them, and aggressively withheld from them. It's not this they didn't tell them about it. There were people stopping them from being treated, and of course they weren't notified about that. Really horrific, study, because it exploited men, and they suffered, their families suffered. So it really is something, a huge mark on the research enterprise, and something that we certainly hear a lot about as a barrier to people participating in research. But the thing that I would say should tell you that this is different is, look at those studies I showed you. There are more white people than anybody else in these studies, right? We have report after report of rich white people going to poor communities, getting in their lines to get the vaccine. They're getting other people's vaccines. This is not a study where it was just Black people in it. This is a study where we struggled. We try and get more Black people in it, but there are folks lined up trying to get in these studies because they know that this is the easiest way for them to be safe and protected, and for them to return to some semblance of normal life. And this is, again, for populations of people who were less affected than Black and Latino and American Indian people. Like, they're still like, no, I need to get the right. So if you're thinking about those things, like, well, there's got to be something different there. They're people who nobody would have been getting in line to be in the syphilis study, in the Tuskegee experiment, to have penicillin withheld from them. That's a very different situation, and I don't want to minimize the impact of the exploitation that has happened in the Black community and in other communities, because it wasn't just with Tuskegee, it's been with other studies. So we have a right to question and pause and be concerned, but we also need to look at the data and the circumstances, which clearly indicate that this is a different situation.
And I'm sorry, I just thought of one last question. Just in case someone cannot, they don't have a ride, can't get to the actual place where they're giving out the vaccinations. I know you're in Tennessee, but is there maybe a place people can start, maybe call the health department, or is there something you could recommend if they need transportation to get the vaccination?
I don't know specifically in the Birmingham area. I would say call your public health department. I did communicate with my good friend, Dr. Shantice Allen, who I know is
Yeah.
in Birmingham. I know she was working with some of the COVID-19 projects early on, but I don't think she is now. I can certainly check with her and get back with you. But I think you already know her. You might be able to
I
get
know
that.
already.
Yeah.
Yeah,
Okay. So
contact her too. Yeah.
yeah.
Okay.
Okay. Yeah.
Okay, awesome. Well, could you please tell everyone, just first of all, thank you so much for making yourself available to do this for us, to keep us all educated, informed about COVID-19, the vaccinations, and everything that's surrounding it. Thank you so much for that. Can you tell people how we can follow you on social media?
Oh, yes, I do have social media. So I can't say that I'm the most active on it, but I'm on Twitter. That's usually where I'm more likely to post, and that's at DRCH Wilkins, Dr. CH Wilkins, WILKINS. That's the same for me on Instagram, but I'm really only on Instagram so I can try and stalk my teenagers there.
No, that's right. See what they're doing.
Yes,
I
yes,
get
yes.
we've been there. Well, thank you so much. I appreciate it. And thank you all our viewers who actually posted questions. We thank you so much for you guys as well. So thank you so much, Dr. Wilkins. We appreciate it.
Thank you. Thank you. I appreciate the opportunity.
Thank
Take
you.
care.
All right. Bye-bye. Take care.